My name's Judy Talley, and I'm with PMD Alliance. And you may all see that Julie is also here from PMD Alliance. And we are really thrilled to have Dr. McFarland with us, Dr. Nick McFarland. And just to let you know a little bit about him, he's going to be talking about Parkinsonisms. So we've got a lot to learn. And Dr. McFarland is an MD and a PhD, Associate Professor of Neurology in the Movement Disorder Divisions of the University of Florida College of Medicine. So he is an active member of the Center for Translational Research in Neurodegenerative Disease, and actively involved in multiple clinical trials for atypical Parkinson's disorders. So he's a medical doctor and a scientist as well. Dr. McFarland, I want to welcome you and can't wait to hear what you have to say. We'll have folks, if you have questions as Dr. McFarland goes through the information, use the chat at the bottom of your screen. And just type in your chat. We'll be following them as we go, so you can ask your questions when they're on your mind. And then at the end, we'll take some time to go through those questions. So Dr. McFarland, welcome.
Thank you so much, Judy. I really appreciate it. And I really appreciate being invited to do this and to talk to everybody today. This is sort of a topic that is special and close to my heart. I do see a lot of Parkinson's patients, but one of the areas that I'm most interested in is atypical Parkinson disorders. And I'm going to talk about those today. The title of my talk, I will go ahead and share a screen. I think you're going to be able to see my face as well as we go through this. And I will try not to race through everything today, but I have a lot of slides. I want to cover a kind of a broad topic about atypical Parkinson disorders and what they are. I've been doing this for a number of years. We have a multidisciplinary clinic here at the University of Florida at the Fixed Cell Institute for Neurological Diseases that includes care for patients. We like to book people into our rehab. We have a couple of social workers, nutritionists or dietitians, and we have a huge team that does research in these disorders, as well as many other neurological diseases. So we want to see you, and we would like to help in any way we can. So without further ado, I'm going to go ahead and just forward my slides here a little bit so we can talk about things today. This is sort of the outline of things. I'm going to talk about what's called Parkinsonism and the atypical syndromes. And I'm going to divide them up into both what we call synucleinopathies, and I'll come back to that. These include Parkinson's disease, Lewy body, and multiple system atrophy, or MSA, and then the tau disorders. We call those tauopathies, or it's called PSP and corticobasal syndromes. And I'm going to discuss briefly treatment options and future directions. Okay, so it's a lot to talk about. So let me move forward. So as you guys know, Parkinson's disease is very common. And I think these charts are actually already old, but just to give you kind of a glimpse of the problem today, this is just Parkinson's disease alone. It doesn't include the other Parkinson syndromes. And I'm going to get into that. But just giving the sense of things are doubling fairly quickly. The estimates are rising. We're here, United States, America, looking at basically 8% of the total. And as things get, as the years pass by, we're really getting close to 2030. The burden of Parkinson's disease is doubling, likely going to even increase there. We have gone from 1 million to now about 1.25 million patients with Parkinson's disease alone here in the United States. So it's a really big problem. And for those of you in Florida, Parkinson's disease is the second most common degenerative brain disease, second only to Alzheimer's disease. And we have about 500,000 Alzheimer's patients right here in Florida. So huge issue. So when I talk about Parkinsonism, both to my students as well as patients, what I'm really talking about is a clinical syndrome, not necessarily a diagnosis. So I know I have a lot of patients who come and see me and they have this diagnosis of Parkinsonism, but weren't given a specific diagnosis per se during their visit, and it's a bit frustrating. So what exactly does it mean? So it is a clinical, or we call it constellation of symptoms, just kind of like fever is it's one symptom, multiple different causes. Parkinsonism actually encapsulates a constellation. So on the right here, I kind of discuss, I like to use acronyms. There's this nice one we use with students called TRAP. So some of the features are tremor, and particularly a resting tremor in Parkinsonism, stiffness or rigidity, slow movement, what we call bradykinesia. Kinesia is movement. The A actually stands for akinesia. So if it gets really bad, patients are frozen, or we call it akinetic. And lastly, postural instability. I'll come back to that, but basically what it means is loss of the ability to right yourself if you're knocked off balance, okay, leading to falls. Okay, so these are kind of common features. You need to have either tremor, resting, or slowed movement, okay, as key features, plus one of the others, to call it Parkinsonism. Now, Parkinsonism is just, again, symptoms. The big question for physicians like myself really is, what's the cause? And then secondly, what is the diagnosis? And both of those go hand in hand more than you think. So, if we see Parkinsonism, I'm going to come back and again to this over and over, if it walks like a duck, talks like a duck, it's likely Parkinson's disease, 9 times out of 10. But that 1 time out of 10, we're looking at something different. So today I'm going to focus on what's called atypical Parkinsonisms or Parkinson disorders, or what used to be called Parkinson's plus syndromes, or may still be that way for many folks. I am going to kind of overlap the diagnostic features with the pathologic features. Now, path meaning what we see at autopsy after death. But more and more, this is playing a role in understanding what is causing the disease. And it's, it's rising in its importance because, well, I hate to say, right now we have largely treatments that, cover the symptoms, but they don't really treat the disease. But we are at a point, at a crux, a really critical point here where we are starting to develop what are called disease-modifying therapies. And these are targeting the pathology, the cause of the disease. So one common feature is this abnormal accumulation of proteins in the brain. So for instance, in Alzheimer's disease, you may have heard of amyloid. Tau is another protein. That's a normal protein that kind of goes rogue, and that's also found in Alzheimer's disease. But it's also associated with a number of diseases I'm going to talk about today. There's another protein that you should be aware of, something called alpha-synuclein. That's common in Parkinson's disease, dementia with Lewy bodies, multiple system atrophy. You're going to see this overlap, but it's clearly important. So there's a lot more going in the brain than on the right here. This is sort of the loss of dopamine cells. But actually these accumulations of protein in brain cells, here's an example, what's called a Lewy body that's filled with alpha-synuclein. That's not supposed to be there. It's almost, you can kind of think of it like a tumor of the cell body. So it's in there causing mucking up the system, causing this cell to eventually to die. This is what we're sort of targeting and the spread of these proteins as they abnormally aggregate and cause disease. So, as I mentioned already, there is a significant amount of overlap. So this is what is challenging for me and most interested in these Parkinson's disease. So common things being common, Parkinson's disease is the most common cause of Parkinsonism symptoms, okay? Now there are secondary causes. I'll come back to that a little bit here. There are hereditary diseases or genetic diseases that cause Parkinsonism. These range from different forms of hereditary Parkinsonism, there are some, ataxic disorders, frontotemporal dementias, even other disorders that are completely different than Parkinson's disease, something like Huntington's disease, which is a genetic disease of abnormal movements, okay? And then lastly, there are these atypical Parkinsonisms. So when I see patients, roughly about 10 to 15% of Parkinson patients or patients who present with Parkinsonism actually have something that's not Parkinson's disease. Either it's some atypical form, which I'm going to go over today, or some secondary cause, either drug or toxin, okay? Now, when I'm looking at patients, I also want you to think again about those abnormal proteins, or basically what is the cause? Why do I have these symptoms? And so we have identified a number of proteins. In particular, I'll point out 4 of them: alpha-synuclein, tau, amyloid, and something called TDP43, or tarred DNA binding protein. I'm not going to focus on this one today. I'm mainly going to focus on synuclein and tau because synuclein is involved in both Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, and then tau disorders are shown here on the right. I've abbreviated things, but PSP stands for progressive supranuclear palsy, and then cortical basal degeneration shown here. I'm not going to talk about Alzheimer's today. I'm going to talk primarily about Parkinson disorders, and particularly those atypical syndromes today. But I want to give you the sense of the overlap and where this becomes quite difficult in the clinic when we see patients. So there are a lot of different causes. I've mentioned genetic causes. So this is kind of this is an interesting way of looking at things. This is a study in Parkinson's disease, actually, not the atypical syndromes, but it gives you an idea of different genes that have been associated. This is what I call a Manhattan plot. So actually, these are all of your chromosomes on the bottom of the plot here. So chromosome 1 to chromosome 21. And what you see are different genes represented in terms of frequency on the y-axis. This is the y-axis shown here. And so their frequency, as you can see, goes up, and there's sort of a cutoff here where they colored things red. And you can see that a certain number of genes actually pop up as being highly frequent as a potential gene that's associated, I'm not going to say cause, but associated with Parkinson's disease. And one of the most common ones is the gene over here on the right called MAPT. That's the gene for tau. Okay. So tau is a protein that's abnormally deposited in brains of patients who have both, well, mainly we think of Alzheimer's, but also frontotemporal disorders, Parkinson's disease, PSP, cortical basal. So I'm going to come back to this a little bit, but very common, not necessarily thought to be a cause. Then synuclein is the other one that pops up here. There are a few other genes that pop up that you may have heard. Actually, this one over here, LRRK2, and this one over here are two of the most common genes that pop up in a screen for Parkinson's disease. These are risk genes. Rarely this one is associated with a genetic form, but mostly risk genes, but highly found in certain populations of. Okay, so I want you to just get a sense that there are genetic factors, and we can do the same thing in the atypical Parkinson disorders. And there are a lot of common genes that pop up here. Okay, now I would be remiss if I didn't say that one of my jobs is also to look for other potential causes. This is just a list of what are called secondary causes or symptomatic causes of Parkinson's. So this is not what causes Parkinson's disease, okay? These are things that mimic Parkinson's, okay? So our job is to kind of look at medications, maybe potential toxins that you might have been exposed to. This is difficult to kind of establish. Are there metabolic issues? We look at brain scans to look at whether there are strokes, vascular, or whether there are masses or maybe a hemorrhage that could contribute to things. You may have heard someone like Muhammad Ali, who had a lot of hits to his head, may have had traumatic Parkinson's. There are even post-infectious causes that can cause Parkinsonism. So there are things that we look at and often sort of rule out. And bottom line, we're looking at, after we've ruled these out, we're looking at a degenerative cause, okay? And there are many of them, okay? So the big question in my clinic when I see a patient who has Parkinson's symptoms really is it something other than Parkinson's disease? Again, I'm going to come back to the duck, okay? Quacks like a duck, walks like a duck, it's probably a duck. But there are some red flags. And these are things that I think patients and family members should look at or should be aware of, okay? And these are things that maybe you want to point out to your physician if this is part of your story, okay? Are your symptoms more rapidly progressive than a typical Parkinson's disease patient? Most people with Parkinson's disease have symptoms for 20 to 30 years, sometimes even more. So it's a rather slowly progressive disease. I'm going to show you the opposite really is true for atypical Parkinson's disorders. Another red flag really is early onset of symptoms, that are very severe, like severe speech, swallow impairment, early gait issues, that's walking, balance issues, freezing early, and I mean really early within the first several years. A weird tremor. As I mentioned, one of the key features of Parkinson's, it's a resting type tremor, but if it doesn't follow that rubric, then maybe it's not really Parkinson's disease. Now, that's not a hard rule. Many clinicians not aware of Parkinson's disease and other disorders use the response to levodopa. Levodopa is the gold standard medication for Parkinson's disorders. For the most part, it's the standard drug for Parkinson's disease patients, at least one of the first that most people get tried on. So if you reach a dose fairly good dose, roughly 900 milligrams of levodopa a day or higher, and you're still not benefiting from it, that's a red flag. So it doesn't mean that you don't have Parkinson's disease, but it certainly means that you should talk to your physician and particularly your neurologist and ask, are you sure? Okay. There are also what are called plus features. This comes from that Parkinson's plus thing. So supernuclear gaze palsy is actually a difficulty looking up or down or even left or right volitionally, okay? So commanding your eyes to look in different directions. This is something that we see in atypical disorders and not in Parkinson's disease. Autonomic dysfunction. Autonomic dysfunction are automatic functions that your body carries out, like blood pressure control, heart rate, sweating, sexual function, bowel and bladder function, okay? Now, of course, you know, up to 30% of patients with Parkinson's disease have autonomic issues, so not everything, it's the degree of symptoms. There are other findings. If you have coordination problems we call ataxia, that these things might suggest multisystem atrophy, and I'll discuss more of that. Early cognitive issues. So dementia doesn't happen early in Parkinson's. It's usually a late onset thing if it happens at all. Okay, so if it happens early in the disease within the first few years, and I'm going to talk more about this disease we call dementia with Lewy bodies. And then there are other odd behaviors like psychosis, seeing things, hallucinations, having odd thoughts, having behavioral outbursts. That can be unusual. And if that occurs early on, that's something that could be a plus feature. Likewise, other odd features like inability to do things, not due to your tremor or due to stiffness, but due to just your arm or your limb just doesn't function right. Jerky movements that are involuntary, okay? And I don't mean dyskinesias, but jerky movements, or a limb that just wants to act on its own, like it's an alien limb or an alien hand, okay? This might spell another disorder that I'm going to come back to called corticobasal syndrome, okay? So again, all right. So if it walks like a duck, quacks like a duck, it's probably Parkinson's disease, but every once in a while, I see patients who have either the swan or the goose here. So I'm going to be talking about these guys on the right-hand side of the slide, okay? The atypical Parkinson for the rest of this hour, okay? All right, and I'm going to start with the tau disorders first because they are likely the most, or some of the most common ones, okay? So what is tau? So tau is actually a normal protein in your brain that binds and stabilizes what are called microtubules. These are like the tubes within your nerves, okay? You can think of it as a support structure, okay? And when tau is hyperphosphorylated, phosphorylation is something that occurs with all proteins. So phosphate atom connects to, or a molecule connects to proteins all the time to regulate protein function. So when there are too many of these phosphates connected to tau, its function's disrupted. And it has a tendency both to aggregate and abnormally bind to microtubules, mucking up transport in cells. It also leads to plaque formation and neuroinflammation. So you have healthy neurons like this with microtubules. They have tau that's associated with it, and when it becomes hyperphosphorylated, if you look down below this gray neuron, tau disassociates from the microtubules and no longer functions like it's supposed to, and it forms these aggregates, and they look like this when they're stained in cells. So again, they look like a cancer, like a growth within your cell as they accumulate. So again, I want to emphasize here, this is a normal protein. It's important for brain function, but it's processed, it's getting phosphorylated incorrectly, and its functions being disrupted, and then it starts to aggregate or clump up like sugar in water. Got too much sugar, it clumps up and forms crystals, okay? This leads to dysfunction and degeneration of nerve cells or brain cells. And it's actually the cause of many different disorders. I like this particular publication and this spectrum of disorders. So I am talking about Parkinson's disorders, but tau disorders are part of what are called a larger family we call frontotemporal disorders or frontotemporal dementias. And they actually have two different pathologies. This protein comes back, TDP43, which I'm not going to talk about, and then tau. These abbreviations stand for ALS or Lou Gehrig's disease, frontotemporal dementia or FTD. And then on the far right are what's are called the more pure tau disorders I'm going to talk about. CBD stands for corticobasal degeneration and progressive supranuclear palsy. They are in this frontotemporal sort of spectrum or map, okay? And this is what I'm going to focus on, okay? So one of the most common disorders that I see, probably one of two, is progressive supranuclear palsy. So I want to highlight this one first. We've done a lot of research on it recently. The prevalence of this disease is roughly about 9 to 10 cases per about 100,000 individuals. So how does that compare to Parkinson's disease? Well, we've got probably 1.25 million patients with PD. We probably, on an estimate, have 30 to 40,000 patients affected by this disease, to give you just kind of a perspective. So this is a rare disorder, but we see enough of it, it's common enough. Onset is on average right around when Parkinson's disease is. So this is about the average. Average for Parkinson's is about 65. Average onset for PSP, I'm going to abbreviate it that way, is 63 to 67. And most people have symptoms after the age of 40. Okay, so I don't have any patients that are younger than 40, and even that is actually pretty uncommon. Okay, this is a more rapidly progressive disease characterized by early falls, early instability. Falls occur often for no apparent reason, and they're usually backwards falls as opposed to forward falls in Parkinson's disease. Although not 100%, nothing in medicine is black and white, okay? The other feature is eye gaze problems, that's supranuclear gaze palsy, and I'll show you examples. And bulbar symptoms. Bulbar symptoms are speech and swallow problems, okay? These are brainstem innervated symptoms that patients have, okay? This is a very progressive disease, average survival. And again, this is average, is roughly 6 to 10 years, okay? Some people more rapid, some people even live as far as 20 years with this disease, just depends. So we'll talk more about some other symptoms. There are this masked face that you get just like in Parkinson's, but it looks even worse, almost to the point of becoming surprised looking, like a stare. There's a lot of slow movement. Vision issues can lead to sloppy eating habits, impaired reading. There are a lot of different complaints. Now, again, I'm going to talk more about this. There are mood and there are cognitive issues as well, okay? The one thing I do want to point out are the two key features, okay? Falls. On the right, look at the graph, okay? Falls for Parkinson's disease on average don't really start to occur except within about 5 years of symptom onset. So with atypical disorders, they usually occur earlier. So basically these diseases are Parkinson's on steroids away. The symptoms occur much more rapidly and are more debilitating. PSP takes this to a different level, okay? In these patients, falls often occur within the first couple of years. So one of the diagnostic criteria is early falls within the first 3 years typically, okay? But there are different ways this disease progresses. But this is a major hallmark of this disease. In addition, let's take a moment to talk about the eye abnormalities. They're fairly complicated, okay? Already with Parkinson's disease, people don't blink very much. They have that sort of masked face. But here you get a lot more complaints. Blurred vision, eye discomfort, because the eyes are drying out. Patients may complain of double vision, difficulty reading. They may have problems opening their eyes, okay? And this is sort of either due to spasms of their eyes where they're closed, or actually the connections between the brain and the eye, so having difficulty giving the signal to open your eyes. So can lead to what we call a functional blindness. So basically the blinders are over the eyes and you can't see, the eyes work. It's just that you have the eyelids covering them. Okay, so what is the issue here? The main issue really is this problem with volitionally moving your eyes up or down, and particularly down gaze. Up gaze decreases with aging, okay? Down gaze is more specific to PSP, and eventually becomes completely impaired, so the eyes just stay at one level. You can imagine how hard that is, the difficulties that can cause. Because the eyes don't move up and down, you don't look where you're going. If you're going down steps, you may fall because you trip because you're not watching where you're going. If you're trying to eat, it's hard to see what you're eating because the bowl's down below your vision, and either you have to push it away from you or lift it up so that you can see what you're looking at. Eventually, both the horizontal eye movements can be affected, and it leads to the stare look, okay? Eye movements are also jerky. So that's what's called saccades. And people could have these jerky things. So you can look at the right here. I'm going to show this video here if it shows. It may not even play. Yeah, it's not going to play. But basically, this person over here has these jerky movements that go back and forth. Rather than in a smooth, we call a sinusoidal pattern, left to right, the eye movements jerk back and forth kind of involuntarily when they fixate on something. So these are signs that I look for as a physician when I'm looking at patients. So I'm going to muddy the water here. PSP nowadays is recognized as a heterogeneous disorder. It presents in different ways, okay? I have mostly talked about the very classic form of the disease that's fairly severe. It's called Richardson syndrome, based on one of the people who actually discovered and first described the disease over 60 years ago now. There are a complicated set of clinical criteria now that recognize suggestive, possible, probable forms of the disease. You can only make a definitive diagnosis still based on autopsy, unfortunately. We don't have one scan that just tells us what it is or a blood test. But we recognize that there are different ways this presents. Sometimes it presents just with the eye abnormalities. Sometimes it presents just with postural and instability or gait issues. Sometimes it presents like Parkinson's initially and progresses to look more like PSP. Occasionally, we just get speech language problems. So there are multiple ways this presents, and I have this long list shown here just to give you a sense of how heterogeneous this is. And on the right, just to give you kind of the frequencies. The classic form, basically, as well as the PSP Parkinson type that overlaps with Parkinson's disease, are the most common forms and make up over basically a third of the disease and the way it presents. The other ones are much more rare, okay? One key feature really is that we now know that if you have symptoms early on that are suggestive, it does predict that one progresses over time to meet criteria for both possible or probable. And most of these other variants, even though they start out with one of the hallmark symptoms, speech, swallow, postural issues, or ocular motor, or we call eye movement issues, they eventually over time progress to look like classic PSP, okay? It just takes a little bit longer, okay? So what do we know about what causes this disease? So I already kind of pointed out, this is a tau disorder. So we have abnormal deposition of tau protein in neurons, but we also have it in what are called supporting cells called glial cells. And this is one example of a very angry looking cell. It's called a tufted astrocyte. This leads to degeneration. There's scarring of the brain. There's marked shrinkage of the brain in different sites of the brain. And one area in particular is the midbrain. So on the bottom, we do use MRIs. So this is just a cut through the MRI right through the middle of the head, showing the brain stem. This is a Parkinson's disease patient with a spinal cord, pons, midbrain. This is the brain stem that looks somewhat normal. A PSP patient, by contrast, has a really small top of the midbrain, okay, shown here. Actually, it looks very much like a hummingbird, like a beaked hummingbird shown here. So this is what's called the hummingbird sign. You may hear this if you have someone or a loved one or someone you may know that suffers from this disease. It's one thing that we can look for on brain scans. It's not always there or obvious, but when we do see it, it can be helpful for diagnosis, okay? So I'm gonna talk about its cousin, the other form of this disease that's also a tau protein disorder called corticobasal syndrome. By comparison, this is even more rare, okay? The incidence of this disease is about 10 times less common than PSP, okay? But the key features really is it's got both Parkinsonism as well as cognitive symptoms. So we have both motor and cognitive and behavioral symptoms, okay? The onset is rather similar. Unfortunately, it's very rapidly progressive, again, with the average disease duration around 6 to 8, maybe 10 years or longer at most. And there's a lot of different overlapping pathologies. The most classic way this presents, and I'll come back to this, is really a very asymmetric Parkinson's presentation. That's the most classic way it presents. Again, I'm going to muddy the waters here. There's a lot of different ways this disease presents. It presents like PSP sometimes. Sometimes there are speech issues that begin, and other times it's just a very cognitive decline. And there are varying pathologies. In fact, let me come back to that in just a second. I want to focus first on, just so you recognize what this really is. Marked asymmetry is the classic way this disease presents. And one of the most common complaints is focal limb dysfunction. And I don't mean just tremor, okay? The limb doesn't do what you want it to do. And that's a key statement that I get from patients often. My hand just doesn't work anymore. And when I examine them, we find signs of stiffness or rigidity. Sometimes we see abnormal posturing, like that we call dystonia. The type of tremor I mentioned early on, if it's not a resting tremor, it's more of a course action tremor. That's different. So it's a typical type of tremor. Again, there can be speech and swallowing issues, eye movement problems, and early balance problems that we don't see in Parkinson's disease. The cortical or cognitive signs that we find in this disease that we don't see in Parkinson's disease often are language problems. I don't mean speech, I mean language problems, either fluency, finding words, or understanding people, okay? There can be this problem we call apraxia, or difficulty with learned tasks. So knowing how to use a fork, knowing how to use a remote, just knowing how to do simple things like mime, like a victory sign, or how to hold a toothbrush, how to dress, putting on clothes backwards, for instance. These are learned behaviors that sometimes become impaired in this disease. Alien limb is really a limb that does things on its own and has abnormal postures that aren't controlled. And often patients don't really recognize it. In fact, they're not even sure it's their limb sometimes. It's a very odd phenomenon. Myoclonus actually is the myoclonic or jerky movements, very fast, okay? This is something that is definitely not seen in Parkinson's. Sometimes there are sensory symptoms, okay? And then this one also is associated with a progressive dementia. Unfortunately, this is very poorly responsive to treatment. Again, I'm going to highlight best predictors. Signs of this are this asymmetric limb dysfunction, weird postures, jerky movements, and later onset of balance issues. Okay. So this, I'll mention again, is a tau disorder, but pathology is only, typical corticobasal degeneration pathology is only present in 40% of cases. So this is a rare kind of bird. In fact, if you want to call it a goose, it's an odd goose. But basically, the pathology overlaps other disorders like Alzheimer's, frontotemporal. So a lot of overlapping different pathologies. But on the right, again, this is just tau pathology. It's both in the cells and even in the nerves. We can look at brain scans as well, and we can see early degeneration of the brain, and sometimes it's asymmetric. So in this patient, you can kind of see the parts of the brain here are much smaller than on the left side of the brain. This is left, this is right, actually. So there's an asymmetry here. It should be more like this, where the folds of the brain are much closer to each other. There's a lot of space, which this black represents, between the brain folds and this patient, okay? We do have some novel testing, and I'm going to talk more about this as we go. Some of this is still experimental, but increasingly, so at the moment, the most widely used tests for these diseases is MRI, and that's all I've talked about. Unfortunately, no blood tests. There are other types of imaging out there. So this is what's called PET scanning on the left here. The top is a PSP patient, and most of the abnormal activity is in the brainstem shown here, as opposed to corticobasal degeneration, where most of it's in what's called the cortex, the higher part of the brain. That's why you get what's called cortical basal ganglionic degeneration. Now, we are increasingly using, we're called ligands to different proteins, and we do have some ligands that bind to tau. So this is what's called a floor tau superior PET scan. And you can actually show by using this still remains on a research basis and limited to very few centers around the United States and the world as well. But you can see here that there's binding of tau pathology in the brainstem. This is the brainstem, and then less in the higher part of the brain shown here. Okay, so this is an interesting new kind of development, and hopefully we'll be seeing more of that as this becomes more available. We're getting tau scanners at University of Florida. However, these new, what are called ligands or tracers, are extremely expensive. So stay tuned. So how do we treat this disease? So I'm going to stop briefly and just kind of discuss PSP and corticobasal degeneration. So despite the fact that these are rapidly progressive, disability occurs earlier in these diseases. Many people tell you that there's not much treatment available, there's nothing to do. That's actually false. So there are ways to treat these disorders. It is true that they don't work as well as they do in Parkinson's disease, but it is worthwhile to try patients on Parkinson medications. A levodopa trial is worthwhile. It may fail, but often patients require higher doses. So a good trial. There are other dopamine-like medications that can be tried. They're inferior to levodopa, and some studies even use this drug called amantadine. We treat symptoms. So if there's abnormal posturing, sometimes we can use muscle relaxants, or some of you may have heard of the drug called Botox that we inject into muscles to try to relax them. That's a good treatment for some patients who have focal dystonic or muscle contractions and can last for a few weeks, often up to 6 to even 12 weeks. The dementia is harder to treat as it progresses, and not everybody has this, but there are memory drugs called cholinesterase inhibitors that are used for Alzheimer's, but also work somewhat in this disease, not as well, of course. Mood is a big issue. The goal here for all of us is to help improve quality of life and essentially keep you going and healthy and active and independent as long as possible. But if you're depressed or anxious, that's a key feature, and that's going to affect you. So treating that is critically important. So there are medications. We focus on antidepressants. There's one feature of these disorders called pseudobulbar affect that's called emotional incontinence. So having crying or laughter that occurs inappropriately. There is a medication called Nudexa that can be used to treat it. We also treat the other sort of more systemic things like the urinary issues, and there are medications for that. And I can happy to discuss those at the end if people have some more specific questions. So I don't want you guys to get the impression there are nothing that we can do. Another half of this, of course, is supportive care and rehab, and I'm going to come back to that for all of these. Okay, physical, occupational, speech, nursing care, social services, all of these are critical. One of the reasons I run a multidisciplinary clinic really is because it takes a village to take care of patients who have these diseases that are rapidly progressive. There are a lot of needs that occur. We want to prevent falls, so walkers, and there may be special walkers. This is actually a U-step walker shown here in this picture, which is a heavier walker with a reverse braking system that can prevent some falls. We want to maintain independence. Speech and swallowing are huge issues that, especially swallowing, leads to aspiration, choking, and is a key risk factor for death. So we want to prevent that, and there are ways to help patients. And again, bringing in the home, nursing care, coordinating care, and social services for patients is really critical to help people with these devastating diseases. So I'm going to switch over from the tau disorders to synuclein, okay? And I'm going to start with one of the more common forms of an atypical disorder. This one's called multisystem atrophy, okay? The synucleinopathies relate more closely to Parkinson's disease in that they share the presence of alpha-synuclein deposits in what are called lewy bodies. Let me talk more about that in a minute. Let's focus on multisystem atrophy and what is it? So its prevalence is roughly about 3 out of 100,000 patients. Onset's a little earlier than PSP, okay? Median onset's about 58 years, okay? Duration's about the same, anywhere from 6 to 10 years from onset, not diagnosis. Some patients, of course, live much, much longer. There is a subtype of patients that live sometimes even 20 years. This disease has many faces, okay? I often talk about the 2 faces. One type of the disease is a Parkinson's predominant type, and the other one is a cerebellar type. So the cerebellum is this piece of brain that hangs off the back of your brain and the spinal cord, the top of the brainstem, that helps with coordination and function. So with the cerebellar type, people often have what's called ataxia, a lot of coordination problems. They may have slurred speech, balance problems, and act a little bit like a drunk person, okay? Parkinsonism we all know about. So that's a key feature of MSA Parkinsonism. For both of these disorders, a key feature is autonomic dysfunction, okay? So whether you have Parkinson's or cerebellar presentation, the presence of marked autonomic dysfunction is required for a diagnosis. And what do I mean? Either having urinary or bowel or having blood pressure we call orthostatic symptoms. That's changes in blood pressure when you stand up, okay, all right, are required. So a few old terms that you may hear about, Shy-Drager, striatonegligence, we don't use these very much anymore. We really call these multisystem atrophy now. One of the main reasons we call them all the same thing, even though they present differently, is that they all have what are called glial cytoplasmic inclusions on autopsy. So we see these presence of, inclusions in cells that stain, they're all stained here with this brown stain that contain alpha-synuclein or Lewy body, okay? Here it's actually in the supporting cells and not so much in the nerves, actually. It's a very interesting disease. So there are diagnostic criteria. I'm not going to go into these in great detail, but bottom line, there's, again, possible, probable, definitive requires pathology, unfortunately. But again, you have to either have a marked Parkinson's or cerebellar syndrome with at least some autonomic dysfunction, okay? There are a lot of other features, and I'm going to go through some of those on the right here, like a different type of tremor, which could be more jerky, even, to the point of myoclonic jerky type tremor, early speech and swallow issues, and often the speech can sound, we call dysphonic, so it sounds soft, sometimes quivering or stuttering, very different than the monotone, slow speech that you get in Parkinson's disease. You can develop abnormal postures, particularly of the hands and feet, abnormal facial expressions, as well as sort of truncal flexion. So patients who have really bent over spines, we call that camptocormia. It's not just in Parkinson's, but also found in multiple system atrophy. There are other features, both breathing issues, sleep issues are huge in this disease, and there's a lot of overlap, okay? Also abnormal mood, and sometimes that emotional incontinence that we call pseudobulbar affect is present in this disease too. So let's start with the Parkinson's type. How do we distinguish the two, okay? So again, it's the different symptoms. So male to female ratio is about the same, more male than female, okay? So it's about a 2 to 1 for male to female in Parkinson's. Here it's about a 1.3 to 1, okay? The type of speech in Parkinson's is soft or hypophonic. Here it's more dysphonic, okay? That's quivering. It's a different kind of speech and it's earlier in onset, okay? The tremor is different. It's not the same pill rolling. It's a jerky kind of tremor, and it might even be a postural action rather than a resting tremor, okay? While Parkinson's disease tends to always be asymmetric, so one side worse than the other, multiple system atrophy, not a rule of, not a hard, fast rule, but can be more symmetrical, okay? But again, one other feature is this autonomic dysfunction that's found. The cerebellar type is different. Again, it's really the type where you see more coordination problems, more of a 1-to-1 sort of male to female ratio. And there are genetic forms, okay? So I'm not going to go into great deal for this, but just so you know, there's a form of pure cerebellar disease that doesn't really have much Parkinsonism. But I write on here is that nearly 8 to 10% of patients also have a combined cerebellar and Parkinson features. So the presence of cerebellar features should definitely be a red flag in Parkinson's disease and make you think, is this Parkinson's or is this multisystem atrophy? Okay. So what can we do to study? So the autonomic symptoms are really significant. There are things that we can do to test that. So if they're really prominent, generally we do lying, sitting, standing blood pressures to test what's called orthostatic hypotension, but we can also bring you into an autonomic lab and put you on a table where we gradually tilt you to test your response to blood pressure. We also look at your response to blood pressure when bearing down, called a Valsalva, and we can detect whether you have what's called autonomic dysfunction. During that test, we also look at sweating. We can measure sweat response to heat, okay? There are other tests that we can look at in terms of bladder and even bowel function. Sleep, as I mentioned, and breathing are very much affected in this disease, okay? Again, there's overlap, but this takes it to a different degree. Whereas, a small portion of patients with Parkinson's have what's called REM sleep behavior. This is where you act out your dreams. And I don't mean just talking in sleep. I mean actually, fighting, running, kicking, punching, during your dreams, okay? This is present in up to almost 80% of patients with MSA, okay? It's either prodromal, occurs before the onset, or it's part of the disease, and does sort of peter out as the disease progresses. There are other things that I list on here. Sleep apnea is frequent, restless leg or RLS is frequent, okay? So many things happen. So we often do sleep studies. And then there's brain imaging, and I'll show you what I'm talking about. So in this disease, two ways that we see. So we see same areas of the brain that are affected in Parkinson's disease, but here, if it's a cerebellar type, we see degeneration of the cerebellum in the back of the brain. And we often see, instead of the midbrain, we see this part of the brainstem called the pons that's affected more or proportionately. And in fact, sometimes it gets scarred, and you can see that scarring on this MRI. This is what's called a hot cross bun sign. We just had, well, we're in that time of year, and hot cross bun, if those of you know what they are, that's exactly what this looks like. There are other features that we see here. We actually see scarring deep within the brain. This is called the basal ganglia. There's a lot of iron. There's also water that's deposited. This is something that we don't see in Parkinson's disease. So this is rarely seen, but when we do see it, it can be really helpful. So imaging is something that we often do to help distinguish the different disorders. So again, I'm going to talk just briefly about some treatments. So this is a Parkinson's disorder. You're going to hear the same things. It's worth trying Parkinson medications. They do work in the Parkinson's phenotype. You may need a higher dose, might be limited by side effects, but it's worth trying. The side effects might be exacerbation of blood pressure issues. So here I'm listing the blood pressure, what's called orthostatic hypotension, the gastrointestinal, the urinary issues, and sleep issues. I'm not going to go through each one of these in detail, but I want you to know that there are treatments for blood pressure to help boost blood pressure if it drops. There's treatment for gastroparesis and even constipation. We have a host of things. We do them in a graded fashion. And neurological referrals and treatment can be really helpful, as well as there's treatment for sleep. Okay, so if you have this REM sleep behavior, trying something over the counter like melatonin can be really helpful. And then we have bigger guns. And of course, sleep apnea contributes to that. And so treating that is really critical too. So lastly, the other cousin to this is what's called dementia with Lewy bodies. And that's in the spectrum we call Parkinson's dementias, okay? So I'll come back to this. So Parkinson's disease, I said in the beginning, isn't always associated with dementia, but nearly 20 to 40% do develop a significant amount of either early or more marked dementia in Parkinson's disease. So that said, not everybody does, okay? And the type of cognitive issues do overlap with other dementias, okay? So there's a type of dementia we see in Parkinson's disease that we call Lewy body dementia, and that's more of an umbrella term for both two different disorders, Parkinson's with dementia or dementia with Lewy bodies, okay, or DLB. So what's the difference between the two really? It's time, okay? So when we see dementia in Parkinson's disease, it's usually a late phenomenon. So the timing is later in disease, okay? Typically when dementia occurs early in disease within the first year or two or coincident with the onset of Parkinson's symptoms, we call that dementia with Lewy bodies. So we kind of put the dementia first, okay? So it is an umbrella term, but this is what I'm going to talk about today for you. There are clinical criteria. It does require diagnosis of dementia. That's the plus symptom. And there are core features, one of them being Parkinson's disease. Now, I might note here that for diagnosis, you only need two core features. So you don't have to have Parkinson's to have dementia with Lewy bodies anymore. So you can either have fluctuating awareness or visual hallucinations and dementia, and that would give you enough to give you dementia with Lewy bodies or this REM sleep behavior, okay? But the classic way we often see Parkinson's with the dementia, okay? And there are a lot of other features that are shown here on this slide. But the key thing I want you to know, this is a dementia disorder with Parkinsonism. There can be a lot of other symptoms along with the hallucination, psychosis. There's autonomic problems, just like with multisystem atrophy. This is a Lewy body disorder, okay? So you're seeing commonalities shown here. And in fact, I got one slide here. Let's just show you, take for a minute here, kind of that I'll just show this list of Venn diagram that kind of gives you this idea of the overlap between the different disorders. So here's Parkinson's, dementia, Lewy bodies, and MSA. Where they overlap, you can see the Parkinson's is in MSA. The Parkinson's is also in dementia with Lewy bodies, okay? You can also see that MSA, there's autonomic dysfunction. There's also autonomic dysfunction in DLB, and there's actually autonomic issues in nearly about 30% of Parkinson's patients, okay? What's different really for each disease is all the specific features, like for multisystem atrophy, the different kind of tremor, the dystonic posturing, okay? Sometimes cerebellar features, the breathing and sleep issues that are different, okay? In dementia with Lewy bodies, you have hallucinations, okay? And other features, particularly dementia, that occurs more often than in multisystem atrophy. Now, a few features that are common on all three is the presence of Parkinson's, the presence of REM sleep behavior, acting out your dreams, and autonomic features, okay? Just the degree to which each one actually occurs. But I want you to see that there's significant overlap, and there are differences in brain pathology though, okay? So again, treatment, we treat with levodopa. Again, a really common feature, kind of same thing for each one of these disorders. It's really useful, but can exacerbate other symptoms. Here, I will comment on the cognitive issues with dementia Lewy bodies. Drugs that treat memory, things like Aricept or donepezil, Exelon or rivastigmine that treat memory or cognitive issues are quite effective in dementia Lewy bodies to help treat the cognitive or memory issues, as well as even somewhat the behavioral issues that occur. We call that sundowning later in the day. So these can be really helpful in treatment. Sometimes it's modest, but in up to half patients, it can have a very significant benefit as well. And there's another drug called memantine. It's important to evaluate the sleep and the other symptoms and to try to treat those. When there's a combination of cognitive issues or dementia plus hallucinations or psychosis, that's where things get a little bit sticky. So treatment of psychosis has to be balanced with potential side effects, okay? So the drugs that treat psychosis actually block dopamine, which is not good for Parkinson's disease. So we have to balance things, and often we just have to, sometimes we back off on the Parkinson medication instead of treating, but where it's really necessary, where it starts to really interfere with daily function in the home or care, that's when we do need to treat it, okay? So again, all of these diseases I mentioned, I hope you guys are getting the sense of sort of all the different features. It takes a village to take care of these patients. Again, I'm going to emphasize the different therapies and rehab and social support. I will mention that palliative care as well, since these progress rapidly, it's important to talk about. I often bring it up earlier in my patients. It's not just about hospice. Palliative care is focusing on your comfort, pain, emotional well-being, and ending life on your own terms. Maybe not in the hospital, maybe with family and friends at home. That's what you'd like. So again, it's not about hospice. It's also not giving up. It doesn't mean that you lose me or your physician as your caregiver. We're stopping all your medications, okay? And this can be a really important feature of your care, okay? Something to discuss. So I'm running out of time, so I really will just quickly mention some things here, is that there are emerging therapies for the Parkinson's disease, and the same thing is happening in the atypical disorders. We focus on categories, so symptomatic versus disease modification. So symptoms is what we got now. What we want is a way to slow the disease down and that eventual cure, okay? We're working on that, and many new therapies or trials are actually coming out that are focusing on this latter one, disease modification, but it's slow. But I want you to say that progress is actually occurring. So one way to target disease is to target those abnormal proteins, either alpha-synuclein or tau. There are repurposed medications, and then there's individualizing treatment, because not everything is the same. So I mentioned both in PSP, MSA, they have different faces, the different ways they present. What works for you may not work for someone else with the same disease that's slightly different, okay? There's a lot of emerging therapeutics for PSP. I'm going to skip that just to show you there have been trials on a number of antibodies to target tau. Two major ones, unfortunately, recently failed. They're on the right. or on the left side of the slide shown here, but there's a whole bunch of other ones that are out there. So I do not want folks to lose hope. There's even vaccines to tau, not the bad tau, not the good tau, but the bad tau in your brain to try to wipe that away to see if that slows disease progression. So things are coming down the pipeline. There's a lot of hope going on. For MSA, the same things occurring. There's a lot of preclinical studies, a lot of experimental stuff. There's tons, just long list of disease modifying things. We are doing some of these clinical trials at the University of Florida. We did this for Diprostat trial here at UF. Unfortunately, that one failed, but there's a whole host of other ones listed here, some of which also failed, but ones that have not been completed and are only getting started. And there's some new treatment drugs, particularly for blood pressure. So a lot of hope here, okay? I'm gonna skip that. So in conclusion, I just wanna say, not everything looks like Parkinson's, not everything that's a duck is a duck. Sometimes it's a goose, sometimes it's a swan. I hope you learned something about the atypical Parkinson syndromes or the plus syndromes. There's a lot of overlap among the different disorders. So I will encourage you, if you think you have something abnormal and you're followed by a general neurologist, seeing a movement specialist, a movement disorder specialist is really critical, okay? And having a team. So seeking out centers, and there are good resources online for different disorders to find the right person. There are treatment differences. It does require a team, and there's hope. Okay, a lot of new treatments coming down and on the block, and we are actually enrolling for some of these trials currently right now. So I'm going to stop right there. Take any questions. This is our big team in the FixL Center now here. It's only part of the team.
Wow, you've given us so much, Dr. McFarland. I don't know if you've been see the chat questions that they come up on your screen.
I haven't I'm
Okay,
still,
you may
I'm going to stop sharing so that maybe I can't,
there you go.
see them if I stop sharing.
It looks like there's one about what is a DAT scan. If you could talk about that and where its usefulness.
Sure.
That was one of our first questions.
That's a great question, actually. So a DAT scan is actually it's a functional scan. So as opposed to an MRI, which is anatomical, shows you a really pretty picture, a DAT scan gives you a picture, but the goal of the DAT scan is to look at dopamine, okay? Dopamine innervation in the brain, okay? So the way it's done is basically it's a cousin of a PET scan. It's called a SPECT scan. They inject you with a nuclear tracer that binds to the dopamine transporter in the brain. You wait a few hours and then they just do a scan and we get a picture, okay, of the brain, and the ligand that they inject binds to the parts of the brain that have dopamine. So in a normal patient, we see this kind of comma shape on both sides of the brain where it binds, okay, that's normal. In a Parkinson patient, we see reduced uptake, and so it looks more like a dot, okay? And it can be asymmetric in Parkinson's disease, which fits symptoms. The key thing to know about this is a FDA approved, okay, imaging that can be done in patients with Parkinson's. But the key thing to understand is that it does not distinguish between Parkinson's disease and atypical Parkinson disorders. All it does is shows you the pathology that's going on in the brain. So helpful to diagnose a Parkinson disorder, but it could be atypical, or it could be Parkinson's disease, okay? So it is a useful scan where there are questions. We don't always get this, a DAT scan, but where we have questions about the disease, is it a Parkinson's or not, it could be appropriate to get one, and can be a useful piece of data. Okay, I hope that helps.
Thank you. And then there were a couple questions about exercise and its impact on progression of these different Parkinsonisms.
So again, you guys are asking wonderful questions. So exercise is probably the single best thing you can do for yourself. I don't mean just, it's good for your overall health, but there is now ample evidence in Parkinson's disease and Parkinson's disorders that exercise is critical. Any kind of exercise, and actually it's really more important the exercise that you'll do. So if I tell you to, walk and you can't walk, you're not going to do it. So Or if you hate using your treadmill, you're not going to ever step on that treadmill. So you need to find something that you like. But any kind of exercise, and there's evidence from, basically Tai Chi, yoga, to your running. Now, of course, more strenuous exercise seems to be a little bit better, but you may not be able to do that. That is not that important. Just being active, okay? It's all about inertia, okay? So the concept of inertia, an object at rest will always stay at rest and will grow moss, basically. So if you stay moving, you will keep moving, okay? And so that's really part of the reason why it makes a difference. And in fact, exercise can give a sustained benefit for the rest of your day. And some people feel better for a whole day, if not even the next day after they do exercise. It does take a little effort. If you've not been exercising a long time, you should probably see your general practitioner, talk to them about, are you healthy enough to do exercise? You don't have any conditions that could put you at risk. Make sure you're cleared. But if you are, take it slow in the beginning. It's going to be a little early pain, but it will be worth it over time. Gradually ramp yourself up, okay? You may talk to a therapist to create a program for you if you've been out of the exercise kind of program for a long time.
Okay, and then I think we've got room for one more, if you don't mind going a little over. And there are some questions about the progression, the length of I guess, the lifespan with dementia with Lewy bodies versus Parkinson's disease dementia, and then also if there's some clinical trials for Lewy body dementia.
Sure, good question. As I mentioned, we think about Lewy body dementia as an umbrella term. So there is Parkinson's disease with dementia, and the dementia occurs later, okay, in Parkinson's disease. So Parkinson's disease can have a very long, gradual progression. Of course, we know there are some subtypes of patients. Some people have a more malignant, kind of very rapidly progressive Parkinson's, whereas there's a bunch, nearly half patients have a more benign, kind of very prolonged, to be 20, 30, if not even longer years. The dementia may not occur till much later. Once it starts, though, it does progress fairly rapidly, okay? The flip side really is when dementia occurs early, like in dementia with Lewy bodies. We now know that from onset of the dementia, or at least, from diagnosis, it can be 3 to 4, and sometimes it's only about 6 to 8 years. So it is fairly rapidly progressive if it occurs only. So it does make a big difference. So diagnosing what's called dementia with Lewy bodies, we believe, is really critically important. It makes a big difference in prognosis, and we want to be here to help you. There are trials. There's a lot of research ongoing. There's even one that just was recently published that's, are going to be published, that looks promising and may go into a phase 3 trial soon, but I don't have information on when that will happen, but they keep saying soon. So there is progress. So stay tuned. We'll let you know.
Okay, well, we've run out of time. Thank you so much. I know there were a lot more questions. We could probably be here all afternoon, but my guess is you've got some things probably on your calendar to.
Sure.
So thank you.
Yeah, I'm happy. If you want to send some, I can maybe answer some on your blog or your email. Okay. Happy to do that for folks, but I really appreciate the time and the opportunity to speak to everybody on this important topipic. Well, thanks so much for your afternoon.
Thank you so much, Dr. McFarland.
Great to see you all.
And good to see you all. Check in a day or so if you want to view this video on our YouTube channel. It will be available for you to take a second look at. So have a wonderful day, and just check in with us at PMD Alliance, see what comes up next. Okay. Our goodbye, and have a wonderful rest of your day.